quite fast because there is a lot of information. And okay, we are starting with angina pectoris. This is, in fact, the first symptom of the chronic coronary syndrome. In fact, angina or chest pain is a clinical syndrome usually characterized by episodes of pain or pressure in the anterior chest, but not only in the anterior chest. We are going to see during the presentation. The cause is usually insufficient coronary blood flow. This is the typical myocardial ischemia, which results in a decreased oxygen supply to meet the increased myocardial demand for oxygen. Let's say, speaking generally, it's a disbalance between the supply and the need of the myocardium. And this is the mechanism of tissue oxygen level insufficiency. So in case the oxygen demand is higher and the oxygen supply is lower, definitely this is this balance that is leading to ischemia. In fact, ischemia is lack of perfusion or lack of oxygen and lack of hemoglobin. In fact, the myocardial ischemia can be a result of a reduction of coronary blood flow. This is the most typical, or abnormal constriction or deficient relaxation of the coronary artery. So in one of the biggest reasons can be atherosclerosis, so real stenosis, fixed stenosis of the coronary circulation, or prolonged spasm or reduced oxygen carrying capacity of the blood, like, for example, in some anemic situations. But let's be clear. Reasons for ischemia, they can be multiple reasons for ischemia. This is in fact a list, and this list is not in fact the complete list of possible ischemia reasons. It can be also not only spasm, I already mentioned, but it can be microvascular dysfunction. This can be, of course, atherosclerotic stenosis, endothelial dysfunction, platelet dysfunction, microemboli, oxygen transport impairment, energy substrates carriage impairment, mitochondrial dysfunction, or aberrant origin of the arteries of the heart. So we are starting one by one to take a look at the causes. The coronary atherosclerosis is the most frequent one. But of course, more than atherosclerosis, it can be a situation in which the demand of the supply is much higher. This can be hyperthyroidism, exercise, anemia, hypertension, aortic stenosis, obstructive cardiomyopathy, and coronary artery spasm as well. The schematic on the right is showing what is the effect of the fixed atherosclerotic stenosis. So you can see that it's an obstruction of the lumen of the vessel, and this is leading to decrease of the flow after the stenosis. So in difference of the stable coronary syndrome, the unstable angina is a different animal. The unstable angina, in fact, is a situation in which this fixed stenosis is increasing. So it's not already fixed, but can be, they have aggregation, acute aggregation of thrombus or spasm and other situation in which the clinical situation can be unstable. We are going to speak more about unstable angina on the second part of the lecture. One of the variants of the chronic coronary syndrome is the Prince-Metal or variant angina. It's usually considered that the spasm is the most frequent cause. In case we have a patient with chest pain, we need some kind of protocol. We need an algorithm and several steps in order to evaluate by clinical, laboratory, and strategic point of view. So in case the symptoms are relatively stable, what does it mean, stable? In the stable angina, we have the so-called threshold, pain threshold. So the patients know that in case they can cross 200 meters and they receive chest pain, this is the threshold, the fixed threshold. So the most typical is that the patients know very well when they are going to receive the chest pain. So this is the typical angina. So it's the typical chronic stable angina. So we have to evaluate first by clinical point of view the patient if there is a fixed threshold of exercise, or it's a crescendo. So there is a decrease of the exercise that can cause the chest pain. In case there is a decrease into the effort, this is typical for unstable angina. As a second step, we have to consider several comorbidities and quality of life, like thyrotoxicosis, like pregnancy, like anemia, like, for example, bleeding, other type of anemia. So we have to discard precipitating causes for this clinical situation. The step, probably the most important step during the chest pain episode, is the resting ECG. In case during chest pain, the ECG has abnormalities, in most of the cases is ST depression or negative T waves. So in the worst case, ST elevation. This is the most typical constellation, chest pain plus ECG changes, telling us that most probably the patient has coronary artery disease. Together with the ECG, we have in the armamentarium the echo and also echocardiography, ultrasound-based investigation, and also other type of investigation like scintigraphy or MRI, in order to take a look at the abnormalities in the movement of the heart. So this is the most typical situation in which the patient has chest pain. The left ventricle ejection fraction, so the motility, is going down, and there is segment changes of the heart. And this can be very convincing that the patient has coronary artery disease. Into the clinical practice, one of the most important questions is the pre-test probability. So in case we have elderly people and people with several risk factors, the probability to have coronary artery disease is higher. And after that, we are going, having in mind the clinical situation and the probability, we are going to have diagnostic tests that can show us that the patient probability to have coronary artery disease is higher. This is already mentioned: ECG, echocardiography, MRI, CT, and of course coronary angio. But the coronary angio, because it's more invasive, is in fact indicated for the patients in which the non-invasive tests have shown high suspicion for coronary artery disease. Okay, let's go on these steps a little with more details. So in case the patient has chest angina, we have to take a look at the location, the character of the pain, the duration of the pain, and the relationship to exercise. So this is the most typical relationship to exercise. The typical, the duration of the discomfort is brief, less than 10 minutes. So in most of the cases, the patients are exercising. After stopping the exercise, the pain is in fact is decreasing and disappearing in less than several minutes. or in the other situation in which there is a chronic coronary syndrome and the patients are already medicated. In most of the cases, short-acting nitrates sublingually also are stopping the chest pain in seconds, even not in minutes. The pain is described by the patients as pressure, tightness. It's not acute pain. In most of the cases, pain in a point, and acute pain in most of the cases is not related to coronary heart disease. So the heaviness, the pressure, the tightness is the strangling, the constricting sensation. It's typical for the typical chest pain. About the localization. Localization is very interesting question. To be fair, in our clinical practice, and we are going to be convinced in your clinical practice, that in the typical upper chest, in the middle of the chest, pain on a broad surface, this is the most typical considered. We can in fact observe such a typical chest pain tightness in the middle of the chest in not more than 30% of the cases. So in most of the cases there is some localization and irradiation of the pain also to the shoulders, to the neck, even to the ears, to the jaw, to the fingers, so it's and even on the back and the epigastrium. As you can see, the localization of the pain is not the leading symptom that can say and that can tell us if the problem is from the heart or not. So we are going to have in mind also the other characteristics, the relationship with exercise and the fast disappearance of the angina with the interruption of the exercise. So what about the grading? The grading of effort angina, the chronic angina, is very important in order to decide if we can still medicate the patient in order to release the functional class, to go from a high functional class to low functional class without sending the patient for coronary angio, or in case there is a high class of angina, even with medication. In this case, we are going to perform the non-invasive investigation, and finally we can perform coronary angio. Depending on the level of the exercise that the patient is exerting before receiving chest pain, we have in fact angina with strenuous exertion. So this is the presence of angina during running, rapid walking, prolonged ordinary activity, and so on. So more than usual exercise, much more than usual. Okay, second grade, second functional class is the angina with moderate exertion. What does it mean? This is the slight limitation of the ordinary activities like long distance walking, after abundant meal, in cold. That is very typical, by the way, when the patient is going out from the room to a cold weather, they receive with the addition of spasm, coronary spasm, the patients can receive chest pain, and also under emotional stress. But for example, walking uphill, climbing more than one flight of ordinary stairs at a normal pace, this is the angina typical for second functional class. Third functional class is the angina with very mild exertion. So having difficulties walking 1 or 2 blocks without uphill situation, or climbing just 1 flight of stairs, this is already third functional class. And of course, the fourth functional class is angina at rest. Okay, so I mentioned already the comorbidities and other causes of symptoms. So we have to have in mind other precipitating factors. The step 3 is the basic testing. Of course, one of the most important is the biochemical test in order to decide if the patient is with chronic angina or it's acute coronary syndrome. The most typical, in fact, determinant is the biochemical test and the positivation of the enzymes and also the troponin. I'm going to speak more about the troponin after that, but definitely the biochemical test can tell us if the patient has is not only ischemia but also necrotic injury, and this is typical for acute coronary syndrome. And because of that, the most important is to go for the biochemical test and to make full investigation of the other precipitating factors like low hemoglobin. And in order to take a look at the probability, we are interested in the level of the cholesterol, level of the blood sugar, because the high cholesterol and the diabetes are one of the most important risk factors to have coronary artery disease. Part of the basic testing is the ECG. I mentioned already that the 12-lead ECG with acute changes during chest pain is one of the most typical non-invasive testing that can show us that the patient has coronary artery disease. And what are the typical changes into the ECG during chest pain? Of course, this is the normal ECG in which the ST segment is on the isoelectric line. The isoelectric line is very important to you on an ECG to have in mind your virtual isoelectric line. This is the line that is in fact connecting the PQ segment between three consecutive QRS complexes. So in case you connect the PQ line between three consecutive QRS complexes, this is your real or your virtual isoelectric line. So in case compared to the isoelectric line, we have some depression, like in this case. You see that the ST segment I'm showing with the mouse, the ST segment has a ST depression, especially downslope or horizontal. You see that there is in fact depression of the ST segment below the isoelectric line. In this situation is horizontal, in this situation is downslope. These two are the most typical, downslope and horizontal depression of the ST segment during a chest pain is very typical for coronary artery disease. I mentioned already that the ST elevation is the most dramatic and most, in fact, proven situation in which we can expect a big coronary disease and a big burden of the ischemia. So big part of the myocardium suffering by the ischemic event. These are several ECG that I'm showing. For example, there is a depression. This is from the real life. Depression here into the third and also into the second lead. That is typical for the chest pain with inferior leads depression. And here is inferolateral. So you know probably that we have chest leads and peripheral leads. from the peripheral leads, these are the first, the second, the third, and AVR, AVL, AVF. And the chest leads are from the first C1 to C6 that are in fact positioned on the chest in order to have some notion which of the segment of the myocardium is involved into the ischemia, and of course to try to guess which of the artery is guilty for the ischemia. For example, here we have into the lateral leads C5, C6, and also second and AVF. This is the so-called inferolateral, because second, third AVF are inferior leads. C4, C5, C6 are lateral leads. So this is the inferolateral ischemia during an exercise, during the exercising of this particular patient. This is very dramatic. In fact, increasing of the changes during the exercise. You saw in the previous slide very slight changes, and during the exercise is increasing in fact the level of examination of exercise. And you see here into the second and third, this is already downslope depression of the ST segment, and also horizontal, but deeper and deeper into the V5 and V6. You see V5, V6 very prominent, a little less in V3, V4, and also very prominent in the second, third, and AVF. It's more than obvious. It's a very big burden of ischemia, for such a patient. In such a situation, please note the ST elevation into the AVR. This constellation of depression in many leads, ST depression in many leads, and ST elevation in AVR lead, in most of the cases, in many cases, it can speak us about left main coronary disease or involvement of the proximal segments of both complex and left anterior descending artery into the ischemic syndrome. Again, this is a patient, very interesting patient of 67 years old, who had complaints, chest pain, even during resting and during very small exercises. Again, with very prominent ST depression, you see into the V3, V4, V5, V6, quite a large zone of ST depression. So, second step after the ECG is, of course, the left, in order to decide what is the abnormality of the wall motion of the left ventricle, is the echocardiography. So the ultrasound has very high class and a good level of evidence that the changes, the acute changes into the movement of the heart, are even more specific compared to ECG, in order to decide and the probability the patient to have coronary artery disease. Of course, the chest X-ray is also important in order to take a look at the lung and heart situation. In case the patient has enlarged heart on the chest X-ray, we can guess that the patient is with ischemic cardiomyopathy and has also heart failure. And on the same way, the chest X-ray can tell us if the patient has a problem with the lung during the chest pain, and has unfortunately has also heart failure. I have spoken already about the pre-test probability. So the pre-test probability is very important to have in mind. And the most important determinants of the pre-test probability are the age, the sex of the patient, so the older the patient, and male population, the higher the probability. The typical chest pain also is very important, and the presence of dyspnea, that is telling us for acute heart failure, and the presence of dyspnea is also included in this probability investigation. So in case the patient is with dyspnea, typical chest pain, male, older, diabetic, smoker with elevated cholesterol, this is giving us extremely high probability. In case the patient has often chest pain, the probability to have coronary artery disease is very, very, very high. And on such a situation, we don't need even ECG in order to guess probably with 100% probability that the patient has coronary artery disease. So in case we have high probability, we are going to have as a screening or CT angio that is included now into the guideline, MRI, cardiac MRI, or in case the patient has relatively mild to moderate exercise angina, we can allow ourselves to send the patient also for stress CT or stress scintigraphy, so to use nuclear investigation in order to take a look at the supply of the heart. I mentioned already the ECG stress test, but also we have the other options into the armamentarium before going to coronary angio, and to during the coronary angio to decide which are the stenosis that are guilty for the problem, and if these stenosis are important or just mild stenosis, or they are significant stenosis. So in patients with extensive coronary artery disease, the coronary CTA and the ECG stress test is also very important. This is once again, this is the situation in which we have the combination of ECG testing combined with positron emission tomography or the cardiac MRI or the stress scintigraphy. This is more or less several pictures about the stress testing. You see here are the electrodes, and this is the veloergometer. That is, of course, the exercise can be with a veloergometer or treadmill in order to take a look at the ECG. A very important detail. We are measuring the depression or the elevation of the ST segment from the J point. The J point is very important. In fact, this is the transition zone between the downslope part of the R of the QRS complex and the ST segment. So this is the J point is in fact this point in which the depression have to be measured in order to have the exact measurement. The coronary CTA. Go, Gyurgiev. The coronary CTA I mentioned already, that is already into our guidelines, and the coronary CT can tell us, and coronary MRI can tell us if the patient has some coronary artery stenosis, and if the patient has in fact the indication to go for coronary angio as a golden standard, or to go for a surgical or percutaneous revascularization. In this example is very nice example showing us a critical stenosis of the left anterior descending. This is a coronary angio. This is a CT angio, computer tomography, And you see, this is the reconstruction, and this is the simple picture of the stenosis, critical stenosis of the left anterior descending artery with the presence of calcium. Okay, this is more than 90% stenosis. This is an example of stress test combined with stress scintigraphy. In the stress scintigraphy, in fact, this is the so-called SPECT, single photon emission tomography. In most of the cases, we are using technetium. This is a nuclear agent, nuclear radioactive agent. In fact, venous application with of nuclear agent like technetium, and the exercise is causing, in fact, difference between the situation and during the stress. And in case the opacification, so the perfusion, we are measuring the perfusion. In case the perfusion during rest is higher compared to the perfusion during the stress, this is telling us that during the stress we have this balance between the demand and the necessity of the myocardium, like shown also here. And here you can you observe that during the rest everything is very well supplied, but during the stress into the apical zone, you see it, here is the apex very well supplied, but here we have a spot of reduced nuclear agent opacification. I mentioned several times that the echocardiography is very specific. Why? Because during the ischemia, so lack of perfusion, one of the first in fact details, the first disturbance is wall motion abnormality. So the ischemic myocardium cannot move, cannot exercise, because the muscle, the myocardium mass, needs the supply in order to move. And when we see segmental changes of the movement of the left ventricle myocardium during exercise, this is very, very typical, very typical to guess that the patient has a stenosis of a vessel that is supplying this myocardium. Other detail that can be observed during the exercise, this is the mitral regurgitation that is acute. So in case the patient doesn't have mitral regurg during rest, but has mitral regurgitation during the exercise, this is also telling us that the patient has probably ischemia on the papillary muscles that are important for the coaptation of the leaflets of the mitral valve. And in situation of ischemia, the papillary muscles of the left ventricle are moving slower and less, and this is causing, in fact, the mitral leaflets not to coapt very well and to have mitral regurgitation during the stress test. This is a second examination that you can see here in rest, very mild mitral regurg and big mitral regurgitation during the dobutamine stress test. So the stress can be exercise stress or catecholamine stress, like the usage of dobutamine. It's a modern approach to take a look at the MRI, and because it's again it's not an X-ray investigation, and we don't need any X-ray or contrast in order to take a look at the movement of the heart under the MRI, and to take a look at the movement of the heart under the MRI. That is absolutely very safe, very, very, very safe. And what about the risk? In fact, it's very important to have in mind what is the risk of clinical events for a particular patient. And because of that, the burden, the mass of the myocardium that is involved into the ischemia, the investigation, the evaluation of this burden is very important. And like stressed here, in case we have less than 10% of the myocardium investigated by stress scintigraphy, positron emission tomography, or single photon emission. In case we have less than 10% of perfusion defect or more than 10%, we can guess that the patient has a lower or higher risk of clinical events. On the same way, in case of echo, stress echocardiography, we have more than 3 of 16 segments. So in order to have good possibility for calculations, the myocardial mass is divided on 16 segments. And both on the echo, we are searching for more than 3 segments with impaired movement, or more than 2 segments on the cardiac MRI with impaired movement. This is telling us for higher probability of high risk, clinical risk, and also the investigation on the CT or standard invasive coronary angio, findings such like left main coronary disease, I already mentioned, or proximal stenosis of both left circumflex and left anterior descending. This is also carrying high clinical risk. Or speaking about a particular stenosis, the FFR, this is the fractional flow reserve, more or less, in order to have clear, it's showing us the fractional flow reserve is something like measuring a gradient, pressure gradient before and after the stenosis. In case we have gradient of this stenosis, it's obvious, or FFR or IFR less than 0.89 or FFR less than 0.8. In this situation, it speaks about a big gradient, so it speaks about significant stenosis. And several times I have mentioned that in case of symptoms, the big symptoms, high functional class, increasing severity of the complaints, functional assessment with these methods, the proof of high burden of myocardial ischemia, all these are proofs for high risk, high clinical risk, and it speaks about the necessity, the indication for revascularization. Speaking about classical conventional coronary angio, this gentleman, Mason Sons, in 1958, by chance, with his catheter positioned into the aorta, in fact, up to this date, up to this performed by incident selective coronary angio, the coronary arteries were visualized with the simple injection of contrast into the ascending aorta, proximal ascending aorta, especially in the sinuses, sinotubular junction region. In this episode, the catheter, the Sons, the brachial catheter, entered by chance the coronary artery. In this situation, the right coronary artery, and the contrast was injected selectively into the right coronary artery. The patient had ventricular fibrillation because of the quantity of the contrast that was injected was very big, but fortunately they succeeded to defibrillate him and to save his life. And this was the first prove that the coronary arteries can be visualized with selective injection of contrast. So since then started the conventional angio as approved as the golden standard to investigate and to prove if the patient has coronary artery disease or doesn't. So what about the treatment? Of course, we are starting first with conservative treatment. And this conservative treatment is starting with lifestyle changes. It's very important for the smokers to quit smoking, for the obese to have healthy diet, for the sedentary style of life to increase physical activity. Again, for the obese patients, it's important to go with reduction of the calories into the meal in order to lose weight. And of course, in case in this situation and these changes, still the patient has complaints with slight and mild physical exertion, the patient have to be medicated. What about the medication? Of course, it's important to emphasize that in all the medicine at all, not only in cardiology, the main goals of the medication and the treatment at all is to improve the risk profile, to improve the prognosis, and second, to relieve the complaints, to relieve the symptoms. Again, in the chronic angina, it's absolutely true, and that we have medication that is symptomatic and medication that improve the prognosis of the patient, so to prevent cardiovascular events. And I will mention that the anti-ischemic drugs, so drugs that reduce the ischemia, the so-called anti-anginal drugs, they in fact doesn't improve the prognosis of the patient, most of them, but they relieve the symptoms. So these are symptomatic treatment. We are starting with nitrates. The nitrates have several in fact mechanism of action. The most important, probably not only you, but also many medical doctors can be surprised that the main effect of the nitrates is not the improvement of the coronary flow, but it's the decrease of the venous return. So the reduction of the venous return is in fact decreasing the pressure into the heart and the preload, and reducing the preload is reducing the oxygen demand, and reducing the preload and the oxygen demand in fact is decreasing the disbalance between the oxygen demand and oxygen supply. And this is the main reason, the main mechanism to have anti-anginal effect. Of course, this is important to have in mind that this main mechanism is typical for the oral nitrates. For the venous and intra-arterial application of nitrates, of course, there is in this situation we have already a vasodilator effect on the coronary arteries themselves. So in this situation we have already vasodilation of the coronaries as a second mechanism for anti-anginal mechanism. So there are two types of nitrates. The short acting, that in most of the cases that they are applied sublingually. They in fact have an effect very fast, not more than 1 to 2 minutes. the fast-acting nitrates can release the symptoms because they are acting very fast. The bad news is that they have only 20 minutes of action, and after 20 minutes this mechanism is also already not present, and the patient can receive again pain. The long-acting nitrates have longer period of effect, but because the nitrates are using this SH groups that can be exhausted, and this is the reason that the nitrates have to be taken not more than 2 times a day in order to have some lapse between the application of long-acting nitrates. One of the situation that can in fact escape as an escape from the disadvantages of the long-acting nitrates is to use sidnumimine derivative mosidumine. And the mosidumine doesn't require such a long period of time between the 2 doses in order to have good effect. So these are the most often used anti-anginal drugs. It's schematically shown here. Beta blockers, second anti-ischemic drug with a different action are the beta blockers. The beta blockers are acting on, they have in fact reducing the contractility, and because of reducing the contractility, they are reducing the oxygen demand, and they are reducing the heart rate. With the reduction of the heart rate, in fact, the beta blockers are achieving prolongation of diastole. And you probably know that in fact the supply of the coronary arteries is happening during the diastole. In fact, these are the only arteries into the human body that they receive the biggest quantity of blood during diastole, with the simple reason because during the systole, the myocardium in fact is compressing the coronary arteries, and they cannot receive during the systole any or very reduced supply. And because of that, the medication that is prolonging the diastole, like beta blockers and non-dihydropyridine calcium channel blockers, and also the ivabradine, these 3 medications, in fact, they are improving the oxygen supply because of they are prolonging the diastole. They are prolonging the period of time in which the heart is receiving blood and oxygen. And the third mechanism is also the slower, in fact, beating of the heart is also reducing the oxygen demand. So there are 3 types of mechanism. I mentioned already the calcium channel blockers, but especially the verapamil and diltiazem that are prolonging the diastole. They have in fact 2 mechanisms: prolonging the diastole, like the beta blockers, and having antispastic, anti-constriction effect on the arteries. So they also improving the oxygen supply and have anti-ischemic mechanism of action. The dihydropyridines, like the felodipine and amlodipine, they have only vasodilation mechanism and not prolongation. Ivabradine is the other that is prolonging the diastole with the reduction of the heart rate, but with the I would say with the advantage of not having the negative inotropic effect of the beta blocker. So ivabradine doesn't have any effect on the contractility. Because of that, it can be given in patients with very impaired left ventricle function. Trimetazidine is a very interesting drug that is in fact inhibiting the oral 3-ketoacetylthiolase inhibitor. In fact, this mechanism of inhibiting the 3-cat enzyme, it's teaching the myocardial cells to switch the metabolism from aerobic fatty acid oxidation to switch to anaerobic glycolysis. So to use mainly blood sugar without the necessity of oxygen, using this, in fact, anaerobic glycolysis as a main source of ATP production, the adenosine triphosphate, that is the main burning, let's say, source for the main energy for the synthesis of adenosine triphosphate. When we are using the anaerobic glycolysis, there is in fact reducing the ischemic situation. Also, similar like monocyl nitrate is ranolazine, that is mainly, and also nicorandil, that have effect over the coronary arteries and antispastic vasodilative effect. Of course, there are different kinds of strategies to start. First, with the beta blockers, for example, in patients with myocardial infarction, to start probably with calcium channel blockers with dihydropyridine effect in patients that have already very reduced heart rate. So in this situation, we cannot start with beta blockers because we are going to reduce the heart rate even more. And in some situations, for example, because in 30–40% of the coronary artery disease patients, they have also peripheral arterial disease. In this situation, we are not going to start with beta blockers because the beta blockers are decreasing the flow into the peripheral arteries. And in this situation, we have to start with calcium channel antagonists. So we have to have in mind not only that the patient has angina or chronic coronary syndrome, but also which other diseases the patient has, in order to decide what kind of medication we are going to choose in a particular moment. And of course, more than obvious, we are not starting with all this medication at once. So in most of the cases, there is a stepwise strategy in like titration of the doses of the first medication, adding second medication, third medication, and more than obvious, in case we have more than 2 or 3 anti-ischemic drugs and the patient is still symptomatic and has more than second functional class, we are going to the next step, that is revascularization. We are going to use, of course, coronary angio and revascularization. Okay, let's speak about the prognosis changing medication. In fact, we need, I mentioned already, we need in every clinical situation not only to release symptoms, but also to improve the event rate, to save the patient's life, to prolong, in fact, the life expectancy, and to decrease the probability of have clinical events. In the ischemic heart disease, the most awful clinical event is myocardial infarction. So, which are the medications that are reducing the probability of myocardial infarction? These are the antiplatelets, These are among them, the first one by historical point of view is the aspirin. The aspirin, after that came the P2Y12 inhibitors, and the usage of aspirin and P2Y12 inhibitors, so this is the so-called double antiplatelet treatment, is one of the most important strategy nowadays. Antithrombotics. We are going to speak about thrombus many times when we speak about cardiovascular disease, and it's this is the reason of which many authors and many colleagues are speaking not about atherosclerosis, but they speak about atherothrombosis, because the final step, the most devastating step of the process of atherosclerosis growing, is the thrombosis, thrombus formation. And in order to improve the prognosis of the patient, we have to prevent thrombosis. In order to prevent thrombosis, we have in the armamentarium antiplatelets and anticoagulants. Antiplatelet drugs, they like the name is clear, they are in fact the decreasing the aggregation capacity of the platelets, and the anticoagulant drugs of anticoagulation, they are in fact decreasing the probability of thrombin formation. So the two mechanisms are very important, because without platelets there is no thrombus, because in fact the platelets are the crucial points in which the fibrin molecules are related between each other with the help of the platelets. So both mechanisms, the prevention of both mechanisms is very important. The anticoagulants are decreasing the probability of the prothrombin to grow to thrombin and fibrin from fibrinogen, and the antiplatelets are decreasing the probability the platelets to aggregate to each other with the help of the fibrin filaments. And depending on which level of the coagulation cascade and which enzyme is blocked, we have different the so-called direct anticoagulants, like the unfractioned heparin, or indirect anticoagulants like the fondaparinux and enoxaparin, because and also vitamin K antagonists that are in fact one of the most used anticoagulant in nowadays medicine. But during the last several years, we have also the direct or so-called in the past new oral anticoagulants like the dabigatran, like the apixaban, edoxaban, and rivaroxaban. So because the other more than heparin, the other are using another factors like factor 10. Because of that, they are named indirect, and the unfractioned heparin is direct anticoagulant. And the platelets, antiplatelets, the clopidogrel, prasugrel, ticagrelor, that are oral. They are in fact blocking the P2Y12 receptors of the platelets, and our old friend aspirin is blocking the thromboxane A2 in fact both of them, they are blocking the capacity of the platelets to aggregate. And here are the doses of all this medication, and also how to be applied. In fact, the double antiplatelet is very, very important to reduce the probability of myocardial infarction. And you probably know that one of the most frequent indication for double antiplatelet is the implantation of a stent, the implantation of an intra-arterial implant. So this is in fact the main strategy to reduce the probability of thrombosis of the stent after the application of interventional treatment, especially in patients with myocardial infarction. The oral anticoagulation is absolutely mandatory in patients in which we have episodes of atrial fibrillation. Atrial fibrillation is one of the biggest killers because of the thrombus formation and the risk of stroke, ischemic stroke. In order to prevent ischemic stroke, the majority of the patients after first or second episode of atrial fibrillation have to receive evaluation of embolic risk. And in case there are several very important scales, like the CHATS-VASc scale, that is telling us if the patient has high embolic risk. In all patients with more than 2 points of CHATS-VASc scale have to receive anticoagulation more than double antiplatelet. So patients that are with coronary artery disease and they have episodes of atrial fibrillation, in most of the cases they need antiplatelet and anticoagulation. Okay, we are proceeding with the second strategy for event prevention, so improving the prognosis. I mentioned already that more than double antiplatelet, especially aspirin, the most important two medication that improve the prognosis in the coronary artery disease patients. These are the medication that is decreasing the level of cholesterol, especially the LDL, low density lipoprotein cholesterol. These are the statins. Sometimes in combination with ezetimibe, and these are the modern medication of PCSK9 inhibitor. These are nowadays there are two medication like evolocumab. Evolocumab is one of them that is indicated in patients with high the ischemic risk. These are the patients with high cholesterol, and especially patients with familial hypercholesterolemia, in which the prognosis is the worst. So antiplatelets first, lipid lowering drugs like statin and PCSK9 inhibitor. These are the two. Third one is ACE inhibitors, or angiotensin receptor blockers. These two medications, in fact, in patients in which not only coronary artery disease, but they have already heart failure based on coronary artery disease, the application, the medication with ACE inhibitors and ARB is improving the prognosis with the reduction of heart failure and cardiovascular events. Especially in the patients after myocardial infarction, the beta blockers are improving the prognosis as well. So these four groups are improving the prognosis. Of course, the prognosis is improved, especially in acute coronary syndrome that I will speak later. With the revascularization, we are also trying to improve the prognosis. So the revascularization, in fact, is completing the two goals: to have to improve the prognosis and to release the symptoms. So, what kind of treatment of revascularization? I have spoken already that in case the ischemic burden is high, more than 10% of the myocardium, and we have a high ischemic burden. We have these are the variants, but I will skip that. Okay, we are. Let's say we had already done the coronary angio, and we have proven that the patient has 1, 2, or 3 vessel disease. You know, the myocardium is supplied by 3 coronary vessels, and because of that, in order to decide percutaneous intervention with stenting or coronary artery disease or coronary artery bypass grafting, so the classic, the surgical treatment, or the new endovascular minimally invasive treatment. So we have to have in mind if the patient has multivessel disease, if the patient is diabetic, if the patient has left main artery stenosis plus multivessel disease, and also the results of the team. So having in mind this situation, and having in mind also the anatomical details, anatomical problems that we have into the coronary arteries, we can decide the patient is going for percutaneous or for surgical intervention. Let's summarize in more simple, by anatomical point of view, coronary artery disease. So patients with 1 or 2 vessel disease or with isolated left main disease. In this situation, the syntax score that was derived by the syntax trial. In this situation, the syntax score is less than 22. In this situation, we can allow ourselves and to propose to the patient both CABG or percutaneous intervention. In case the anatomical determinants, the anatomical details are too risky and too complex for percutaneous intervention, and so the syntax score is more than 22, and especially in case the syntax score is more than 33, in this situation, the only option is the coronary artery bypass grafting, and especially in diabetes. So the coronary bypass is improving the prognosis in diabetics more than percutaneous intervention. I'm showing here a clinical case. It's a 65-year-old male with chest pain during ordinary physical activity of 10 to 15 minutes of duration. He has no previous history of known coronary vessel disease, but he's a smoker, and he didn't have any medication. So during the stress echo and even on the rest, he has wall motion abnormalities. So having in mind these wall motion abnormalities, we performed selective coronary angio, and we saw that the patient has a critical stenosis, really critical, more than 90% stenosis of the left anterior descending artery, shown in 2 projections. This is the right caudal projection, and this is the cranial AP, anteroposterior cranial projection, showing again this critical stenosis of the LAD, left anterior descending. In this situation, we have chosen, and the patient have chosen. Of course, in many cases, we are proposing some kind of treatment, but the patient, some patients are canceling. Some patients don't want to have surgical intervention because of the more than obvious, because of the sternotomy. So in this situation, the patient has low syntax score, and he can be treated both by surgical or percutaneous interventions, and we proposed to the patient percutaneous intervention. That was, and you see this is the restoration of the flow and the restoration of the lumen of the vessel after the implantation of a stent. So these were the steps. A second case is a 66-year-old male. Again, in your clinical practice, you are going to see that the coronary artery disease patients are more than 60% male and not female, because of the female hormones protecting the female population by the coronary artery disease. So the patient has a family history of ischemic heart disease. He was a smoker in the past. He had history of arterial hypertension. So he has a high probability to have coronary artery disease, and he has exercise stress test with significant changes on the ECG. You can see that he has not only slight depression of the ST segment, but also during the exercise he has ventricular premature beats, and this combination of ST depression you see here on the V5, V6. This is the propagate V4, V5, V6 depression, and together with the premature ventricular beats, he has a positive stress test. So nothing very important into the laboratory test, and we saw that he has left main mild disease, and he has also stenosis of the right coronary artery that is intermediate. It's probably between 50 and 60%. And because of this stenosis shown onto the LAD, you see here onto the bifurcation of the LAD with the diagonal branch, there are significant stenosis, and there is a significant stenosis of the ostial LAD in this point. Because of that, two wires in order to protect both the LAD and the diagonal branch were put, and the patient, I will show now the left ventriculography also, in order to take a look that the coronary angio in fact is the complex of invasive diagnostic of the heart, is including not only coronary angio, but also left ventriculography. So you see here diastole and systole of the heart during the left ventriculography, showing excellent left ventricular function on this particular situation, with a very good left ventricle. So the so-called multidisciplinary decision making is very important in order to have the best decision for the best patient. Okay, more or less we have finished with the stable coronary syndrome, and I will try now to tell you the most important part of the unstable coronary syndrome. Unstable. Okay, so we have half an hour more. Yeah, I think I will succeed to tell you the most important regarding the unstable angina. I mentioned already that the stable angina pectoris and unstable angina pectoris, let's say, is a disease with the main similar cause. This is the coronary artery sclerosis. This is the coronary heart disease. So both clinical syndromes stable angina and unstable angina are the two phases of one and the same disease. This is the coronary heart disease. Yeah, speaking about gradation, speaking about the steps into the disease. So it's related to aggregation of plaque onto the coronary vessels. So the most aggregation of plaque and most unstable is the plaque is, the higher the probability of full thrombosis in a particular moment. I mentioned already that one of the main goal of the medication in the patients with coronary heart disease is to prevent thrombosis. In case thrombosis occur, there is a full stop of the supply of the myocardium, and in fact this is leading to necrosis, and this is the myocardial infarction. In fact, into the gradation starting from chronic coronary syndrome, going to unstable coronary syndrome, and going up to myocardial infarction. These are in fact the three evolution steps of the coronary heart disease, unless the patient is treated very well and the process of aggregation is stopped. In case the process of aggregation and stenosis, increasing stenosis, it's absolutely sure that the patient, a particular patient, will have in a certain moment will have myocardial infarction. So, what are the criteria for myocardial infarction? There is here is the fourth universal definition of myocardial infarction. So, the detection of a rise and fall of troponin values with at least one value above the 99th percentile of the norma, and with at least one of the following symptoms. In most of the cases, chest pain. These are so symptoms of deep chest angina, new ischemic ECG changes, development of pathological Q waves on the ECG, imaging evidence of new loss of viable myocardium or new original low motion abnormality, and the identification of a coronary thrombus by angiography, including intracoronary imaging, or by autopsy, unfortunately sometimes. This is the definition that is telling us that the patient has the so-called typical type 1 myocardial infarction. So it's a typical atherosclerotic changes caused myocardial infarction. So this is the most typical myocardial infarction. We have 5, in fact, type of myocardial infarction. These are in fact the definition. And the most typical myocardial infarction is the type 1. That is the atherosclerosis caused thrombosis of the coronary vessel. Type 2 is a typical myocardial infarction caused by disbalance into the supply and to the need. So, into the definition of acute coronary syndrome, we have the gradation of unstable angina. So this is angina that is not related to myocardial damage. This is second step, upper step. This is the non-ST elevation myocardial infarction, the so-called non-STEMI. And the final and the worst is the STEMI. This is the ST elevation myocardial infarction. So into the initial presentation in of the cases, the differential diagnosis, the initial diagnosis, the firm initial diagnosis cannot be absolutely sure and absolutely firm. In case the patient is with unstable angina, with non-STEMI or STEMI, we need several more investigation, and these are not only the ECG and the echo, but mainly the laboratory test. The laboratory test is this one that will tell us if the patient has already myocardial injury or it's just a deep ischemia. In case the patient has on the laboratory test elevated troponin and elevated creatinine kinase and muscle brain creatinine kinase and diffraction of the creatinine kinase. In case these laboratory tests are positive, in this case we can speak about myocardial injury, and this patient is not already into the field of unstable angina, simple, but this patient is already into the field of myocardial infarction. That can be non-STEMI. So these are the patients with ECG changes that are not related to elevation into the ST segment, or STEMI. These are the patients with myocardial infarction that can, on the ECG, elevation on the ECG. So the most important is to take a look at the clinical and also the ECG and the laboratory results. What about the clinical presentation of unstable angina? I will now I will emphasize on the unstable angina. So this is this form of acute coronary syndrome that is not related to myocardial injury and necrosis. So in order to have in your brain clear threshold between the unstable angina and the myocardial infarction. So unstable angina is a new onset angina or crescendo angina that is recently been chronic stable angina. We have spoken already about this, the characteristics of the chronic stable angina. So the most important of the unstable angina is destabilization of the periods of the duration of the in fact the angina itself, and you know, in all cases in which the duration of the angina is longer, in which the period of times without angina are shorter, in a situation in which the angina is appearing with lower exertion or lower exercise, all these characteristics are typical of stable angina that is already unstabilized. So this is the so-called crescendo angina. In case we have crescendo angina, we have definitely the characteristics of unstable angina already. In case we have in our practice a patient with unstable angina, the first goal is to decide if the patient has high risk or it's a low risk. What is low risk? In case during the investigation, the patients with unstable angina are characterized by no recurrence of the angina during the clinical episode, no signs of heart failure, no abnormalities in the initial or subsequent ECG, and no rise in the troponin level. These are the patients that are low risk. So in this situation, we can allow ourselves not to send the patient immediately to coronary angio. We can allow to make an initial non-invasive strategy, and in case everything is stabilized, such patients can be left on conservative treatment. But in case of the patient has very critical stenosis or temporary full thrombosis, like shown here on the level, in this situation we are going to have more prolonged anginal pain. We have new onset de novo angina, and we have destabilization of previously stable angina, and we have patient with heart failure during the several episodes of chest pain. In this situation, we are going to have patients with high risk, high probability of a particular patient to go from a simple unstable angina, like shown here. From simple unstable angina, he can grow to non-STEMI or STEMI patient. And of course, this kind of patient, they have to be sent to coronary angio and revascularization. It's very interesting that the more high sensitive laboratory investigation we do, the more the patients with unstable angina and non-STEMI are increasing. So it's more than obvious that the difference of between this clinical situation is just quantitative and not qualitative. The more fine investigation of injury we are using, for example, in case we use myoglobin investigation, probably part of the patients that we consider stable and part of the patients that we consider with just unstable angina, without necrosis, without myocardial infarction, we can classify them. We can classify into the classification of non-STEMI, non-ST elevation myocardial infarction, because the difference between unstable angina and non-STEMI is only the proof for myocardial necrosis. So in case we prove with fine investigation myocardial necrosis, probably we are going to classify more patients to non-STEMI. So what is the pathophysiology of the non-ST elevation myocardial infarction and the unstable angina? This is the rupture or the erosion of unstable atheromatosis plaque. So it's important to emphasize that this rupture and thrombosis can be caused not only by critical stenosis, but also it can be caused by stenosis that was up to that time was even less than 50%. So non-critical, non-ischemic driven. And in case the plaque, such a stenosis is rich of low density lipoprotein, so big lipidic core, so the higher the lipid core is, the higher the probability of destabilization and total thrombosis. So of course this is dependent on many other risk factors like smoking, stress, infection, temperature, plaque hemorrhage, dehydration, and many other risk factors. They can cause desquamation of the plaque and the total thrombosis of the residual lumen. And as I mentioned, it can be caused, of course, by inflammation like here endothelial cell apoptosis, spasm of the guilty vessel, and many other factors. Depending on the damage that is caused by the acute coronary syndrome, this damage, of course, is starting from the endocardium, like shown here. So the most far away zone of the supply of the vessel, and it's growing through the thickness of the myocardium in order to have full thickness damage in this situation. So it can be divided to subendocardial damage to full endocardial damage. Already mentioned vasoconstriction, spasm, vasoactive anti-inflammatory mediators, adrenergic stimulation like cold, cocaine, stress, other drugs, and of course, progressive narrowing of the vessel is also very important. So after this desquamation of the plaque and endothelial dysfunction, after this release of the active factors from the plaque stenosis, this is in fact activating a cascade of thrombosis, and this cascade of thrombosis is dependent on the probability and susceptibility of the patient to form thrombus. And this probability, definitely, I mentioned already, can be decreased by the utilization of the anticoagulant and antiplatelet medication. And of course, also the thrombus that is already formated can be also dissolved by the fibrinolytics. That was in fact the old strategy to treat myocardial infarction, was to put systemic fibrinolytic in order to dissolve the thrombus. But after the application of the modern approach of percutaneous mechanical recanalization and mechanical restoration of the flow, the usage of the thrombolytics as a systemic treatment was in fact put apart because it was carrying the risk of bleeding, allergies, and of course the most devastating bleeding is the brain bleeding. So after comparing the result between the percutaneous approach, the so-called primary PCI, primary percutaneous coronary intervention, with stenting, and the application of the antiplatelets and anticoagulant was in fact the balance went toward the primary PCI. So this of course the chest pain is very similar. The chest pain is very similar to the chronic coronary syndrome, but with this detail that the chest pain is related to dynamic ECG changes. The chest pain is longer in duration. The chest pain is characterized with some other clinical signs like hypotension, sweating, even obnubilation, a low arterial pressure. So in fact this is chest pain that is in fact similar to the chronic coronary syndrome, but have some unstable features, unstable clinical features. And this is a table showing what is the difference between unstable angina and non-ST elevation myocardial infarction. This is very important because, as we have spoken already, in the case there is such a clinical, sorry for that. Okay, in case there is only unstable angina, we have no myocardial necrosis. So this is, let's say, the more beneficial situation. In case we have already non-ST elevation myocardial infarction, in this situation, we have to speak immediately about revascularization. So having in mind ECG changes, laboratory changes, clinical changes, we have to decide if the patient is just with unstable angina, and because in this situation we can treat the patient only with oxygen nitroglycerin beta blockers. But in case the patient has low motion abnormalities, laboratory test increase result, the sign of heart failure, low arterial pressure. In this situation, we have a patient with high risk, and because of that, we are going to think about revascularization. These are the typical ECG changes, typical for an instability. And this is most very, very important to take a look at the ECG during the clinical episode. So one ECG is not enough. We have to make serial ECGs or to have monitor ECG control, because one of the most important determinants of the high risk and low risk is the dynamic ECG changes. So the patients with dynamic ECG changes, like in this situation, ST depression, ST depression, ST depression. In case we have dynamic changes of the ECG, this patient is more classified to high risk. It's probably, I will mention that. I will mention that in the ECG investigation, we have not only this classic 12 leads that I have shown already, but in order not to miss myocardial injury, we can put electrodes also behind, not only on the chest, front chest, but also we can put electrodes on the right part of the chest and also the left part of the back of the thorax. So these are so on the left part of the thorax, but behind, on the back, are the V7, V8, V9. So these are the back, left back leads of the ECG. Or when we are putting the leads on the right part of the thorax, these are the so-called V3R, V4R, and V5R. We are searching ECG changes on the other part of the thorax in order to take a look at the other possible changes in the ECG and the probability a particular patient to have acute coronary syndrome. So these are the high sensitivity cardiac troponin. I already mentioned several times that this high sensitivity cardiac troponin is probably one of the most important determinant to decide if the patient is with a simple unstable angina or with a non-ST elevation myocardial infarction. Already mentioned the myoglobin, like shown here. The myoglobin is very early marker because it's part of the myofibrils, and because the myosin is and the defragmentation of the myosin, of the myofibril is a very early sign of the myocardial necrosis. The earlier we are investigating myosin and myoglobin, and the most fine is investigation, we can classify a patient to the group of non-ST elevation myocardial infarction. So this is the timeline of the rise and going down of the laboratory test during the unstable coronary syndromes. Here are the new biomarkers. I already mentioned the myoglobin, also interleukin 6. That is also inflammation sign. Also neopterin, eostoprotegerin. This is the rapid rule in and rule out algorithm. In case the high sensitive troponin is negative, the patient is low risk. The patient is high, the patient is high risk. In case there are rapid changes on the ECG and the echo during the follow-up, the early follow-up, the patient is high risk. So the patient is going more for the invasive approach. In case there is no ECG changes, no high troponin, no echocardiographic changes, this is a patient low risk. He is for observation several days. In case everything is fine during these several days, he is for discharge and additional investigations, such like mentioned in the previous lecture, like stress test, stress scintigraphy, stress MRI. So this is the triage of the risk groups. So let's say these are the scores. Of course, there are several risk scores, but all of them, in fact, emphasizing onto instability in the clinical situation, changes into the ECG, in fact, dynamic changes into the ECG, and dynamic changes into